non-mass lesions on ultrasound went to biopsy by Professor Nashwa Adel, Professor of Radiology, Minya University.
Bismillahirrahmanirrahim. I'm honored to speak about non-mass breast lesion on ultrasound went to biopsy. First, I would very much like to thank the organizing committee, especially Professor Dr. Nuran Hussein, for inviting me to be with you today. It is really a great honor for me. A non-mass lesion in the breast is a discrete area of altered ecotexture that does not conform to a mass shape, with lack of margin, and can be differentiated from the normal tissue and cannot be assigned to a specific shape. It is important to recognize the finding because breast cancer can manifest as such lesion, and that's why it is reviewed as an item at the 6th edition of BI-RADS lexicon. Non-mass findings have been reported to occur in about 5% of diagnostic or screening breast imaging. A wide range of benign and malignant conditions have been reported to represented as a non-mass finding. There are wide variation of benign rate from 46 to 90 and malignancy rate from 10 to 54. Benign causes include normal variation, accessory glandular tissue, estrogen effect or tamoxifen rebound, focal fibrosis, pseudoangiomatous stromal hyperplasia or BASH, trauma or fat necrosis, and mastitis. Malignant causes include DCIS, invasive breast cancer, either ductal or lobular or mixed, mucinous carcinoma, metablastic carcinoma, and acute lymphocytic leukemia. Ultrasound radiologic feature of non-mass finding have different methods of classification. One of the most important classification done by Bark et al. Study, which classify it according to the distribution into focal, linear, or segmental regional area that does not make a mass shape. Another important classification by Gis et al. Study classified based on ecotexture, which associated hypoechoic, hyperechoic, or mixed. Example bar ultrasound feature of non-mass based on distribution. Figure number 8, ultrasound, 32 years old female patient with a non-mass finding with focal distribution. Ultrasound biopsy was taken confirming radial sclerosing lesion. Figure B show 27 years old female show a non-mass finding with linear and segmental distribution. Ultrasound guided biopsy was taken confirming DCIS. Figure C for a female patient 35 years old with a non-mass finding with rational distribution. Ultrasound biopsy was taken confirming lobular carcinoma in situ. Another example of non-mass based on the ecotexture. Example A, ultrasound picture of a female patient, 31 years old with a hypoechoic non-mass lesion. Ultrasound biopsy was taken confirming DCIS. Figure B, for ultrasound picture of a female patient, 33 years old with a mixed echogenicity of non-mass lesion. Ultrasound guided was taken confirming BASH. Figure C show 45 years old female patient with hyperechoic non-mass lesion. Ultrasound biopsy was taken confirming fibroadenomatous changes with BASH. There are important associated features that raise the suspicion of non-mass lesion to be biopsied. They include calcification, architectural distortion, tubular or ductal architecture, internal vascularity, high elasticity score, and acoustic shadowing. We will begin with one of the most important features, which is microcalcification. It appears at ultrasound as hyperechoic foci differ from the surrounding dendritic tissue. And on mammography, suspicious calcification may be heterogeneous of size from 0.5 to 1 millimeter, or powderish, and microcalcification is 0.5 millimeter, and abnormal distribution, which may be linear, segmental, or grouped as in this picture. Architectural distortion appear in ultrasound as finger-like projection from the lesion. Associated mammography can confirm the diagnosis, whereas area of architectural distortion appear at the upper outer quadrant at mammography. One of the important features also is focal tubular or ductal distribution, which appear at ultrasound as focal duct at the retroareolar region with irregular outline, and at mammogram it appears as focal linear density of beaded appearance retroareolar in location. Guided biopsy at this case was done confirmed DCIS. So we can make a plan for ductal dilatation. If it is bilateral, it is benign. If it is focal or segmental, it may be malignant. So look for the lumen. If there is absent internal echo and echo-free lumen, it is benign. If internal echo is present, look for floating echoes, probably benign. If there is solid lesion with broad-based and irregular, this has suspicious for malignancy. Another important feature is high elasticity score. Elastography improves the specificity of ultrasound for characterization of a suspicious non-mass lesion. Here is color-coded real-time image with hard lesion coded by blue color considered high elasticity score. Picture for female patient, 65 years old, with a non-mass lesion with radiating speculation. Left real-time elastography image show blue color, which is elasticity score 4 and biopsy confirmed invasive lobular carcinoma. Another important feature is the internal vascularity. Color Doppler and Power Doppler also improve the specificity of the ultrasound for characterization of suspicious non-mass lesion. Malignant non-mass lesion have high vascularity, more than 2 vessels. This image shows focal distribution of ducts with soft tissue lesions seen within the duct and heterogeneous calcification, and color Doppler show heavy internal vascularity. Biopsy was done showing mixed invasive lobular and invasive ductal carcinoma. Last one associated feature is the posterior acoustic shadowing, which may indicate desmoplastic reaction and appear at benign lesion like sclerosing lesion or malignant invasive carcinoma. And here is an example for mixed echogenicity lesion with posterior acoustic shadowing at female patient 65 years old and biopsy confirmed invasive lobular carcinoma. Other tools for confirming the diagnosis of ultrasound, one of the most important is mammography. Correlation of mammography radiologic fixture with ultrasound always appear as area of asymmetry. Types of asymmetry: asymmetry, focal asymmetry, global asymmetry, and developing asymmetry. And for diagnosis of asymmetry, we must have comparison of both breasts. First type is asymmetry due to superimposition. It is ill-defined dense lesion with concave border interspersed with fat. It is visible in one standard view, and 80% of them are summation artifact and no need for biopsy. Second type is focal asymmetry, which is visible in 2 projection as ill-defined dense lesion of concave border interspersed with fat, occupies less than 1 quadrant, and so if it is associated with calcification, distortion, and internal vascularity at ultrasound, so it is malignant. If not, it is benign. So we can evaluate focal asymmetry by ultrasound with mammography. If no palpable mass and all previous points of evaluation by ultrasound are normal, it takes BI-RADS 3, with 1% only likelihood ratio of malignancy. Follow up for 2 years with no further change in the size and shape will downstage lesion to BI-RADS 2. But if the focal asymmetry, on the other hand, is palpable and with calcification and distortion internal vascularity, suspicious focal asymmetry will need biopsy. And here is an example with a focal asymmetry noted at the lower outer quadrant of the right breast, with the ultrasound show irregular hypoechoic non-mass lesion with posterior acoustic shadowing and desmoplastic reaction. Biopsy was done showing invasive ductal carcinoma. Third type is global asymmetry, which is visible in 2 projection, an area of density, concave border interspersed with fat and occupies more than 1 quadrant. If it is also not associated with calcification or distortion and not palpable, it is BI-RADS 2. But here is example for malignant case with suspicion at global asymmetry, where is global asymmetry seen at the upper outer quadrant of the right breast, and ultrasound was done showing ill-defined hypoechoic breast lesion by elastography. It take hard and blue color of scale for biopsy confirming invasive lobular carcinoma. Last type is developing asymmetry, with focal asymmetry is new, larger, or more prominent than prior exam. It only may be benign if with hormonal replacement therapy bilateral, but also it is usually by RADS4 and need biopsy. A case of developing asymmetry with line-up study for multiple years showed change in size and architectural distortion of the asymmetry. Biopsy was taken confirming invasive lobular carcinoma. Another very important correlation with the ultrasound non-mass lesion is with breast MRI. Contrast-enhanced breast MRI is a powerful tool for diagnostic evaluation of the non-mass lesion. Ultrasound suspicious non-mass lesion frequently detected as non-mass enhancing at the MRI, with distribution is either segmental or linear, and internal enhancement pattern is clumped or clustered pattern. Example for global asymmetry, here at the breast, with MRI pre-contrast and post-contrast showing non-mass lesion, hypointense at T1 and T2, area of non-mass enhancement of segmental distribution, and clustered ring pattern by RAD4 biopsy confirming invasive ductal carcinoma. So we can make a plan for the non-mass. First, by ultrasound, look for distribution if it is focal, linear, or regional. Look for texture if it is hypo, hyper, or mixed, and look for associated features which increase suspicion of the mass as calcification, tubular or ductal pattern if associated with soft tissue or regular lesion, and if it is architectural distortion associated. Then by mammography, it is asymmetry. We must compare both sides, and for developing asymmetry, we need prior study. And look for elastography, look for the strain elastography and color plane, if it is blue or green, if it is score 4, so it is hard. MRI, look for the pre and post contrast film for non-mass distribution and for the pattern of enhancement. Take home message, radiologists may encounter non-mass finding at screening and diagnostic study. Non-mass findings are significant because it may indicate malignancy, presence of internal vascularity, associated architectural distortion or microcalcification, raise suspicion, and need biopsy. Correlation of different modality will help for more characterization of the lesion. The appearance of non-mass finding in ultrasound may be subtle, yet suspicion should be raised, especially if the non-mass finding detected in the ultrasound in the same area of suspicion on mammogram and MRI. Thank you.
Our next